Good afternoon, and welcome to Ask the Doc. This is the program where our viewers have the opportunity to ask questions of experts in Alzheimer's and dementia research. My name is Dr. Megan Whitbrocht. I'm the Associate Director of Education at UCI Mind, which is part of a national network of Alzheimer's disease research centers designated by the National Institute on Aging, part of the National Institutes of Health. Today's episode is special. Have you all wondered what Alzheimer's disease pathology looks like? Today's guest is not only going to tell us about the brain changes that occur with AD, but she's also going to show us with slides and photos. I am pleased to welcome Dr. Mari Perez Rosendahl, who is an assistant clinical professor of pathology in the School of Medicine at UC Irvine. She's a board-certified neuropathologist at UC Irvine Medical Center, who completed her medical school training at the David Geffen School of Medicine at UCLA and a residency in anatomic pathology at UC Irvine. She went back to UCLA to finish up or to do a fellowship in neuropathology and then came back here. Dr. Perez Rosendahl also serves as a neuropathologist for UCI Mind, where she examines tissue from the brains of people enrolled in the Alzheimer's Disease Research Center longitudinal study. Dr. Perez Rosendahl, I'm delighted to have you on the program to let us take a peek under the microscope with you. Thank you for joining us.
Hi, Dr. Whitbrock. It's so good to be here. Thank you so much for inviting me.
Thank you for coming. And welcome to our live viewers. If you're attending live on Facebook or YouTube, you can participate in the Q&A with Dr. Perez Rosendahl by typing questions into the comments box accompanying the video. Please do note that whatever you post on the internet will be linked to you and visible to others, so please post responsibly. Okay, with that, let's get started. Dr. Perez Rosendahl, can you describe the main clinical responsibilities of a neuropathologist?
Sure. That is a great question, actually, because I think many pathologists are portrayed on TV and in movies as only working with tissues from patients that have passed away, which is certainly true. We do, of course, do autopsies, but one of the most important responsibilities that I have, of course, is brain autopsy, and I'm very excited to talk to you about that today, especially as my role pertains to autopsy for the Alzheimer's Disease Research Center at UCI Mind. But a large portion of a clinical neuropathologist role is providing diagnoses to live patients. So in the hospital setting, which is actually where I am now, the neuropathologist will provide diagnoses on both benign and malignant disease, so both tumors and non-tumors, in not only the brain, but also spinal cord and peripheral nerve and muscle. So a lot of times this happens in real time. And what I mean by that is we do something called frozen sections. So actually, it's sort of an intraoperative consult, if you will. And if you can imagine, there's numerous patients right now down in the operating room that are undergoing surgeries. And so throughout the day, these surgeons and neurosurgeons, in my case, will be sending us a small piece of the patient's tissue. And generally speaking, we need to answer a question. And usually the question is, what is this? Is it a tumor? And generally speaking, what kind of tumor is it? And we actually have 20 minutes to render a preliminary diagnosis. So throughout the day, every day, most pathologists and neuropathologists will be doing this, through the course of the day as surgeries go on in the operating room. And we call it a frozen section because the tissue is actually frozen down quickly, and that allows us to cut it, thin enough that we can actually put it on a glass slide and stain it in such a way that we can give a preliminary diagnosis. And then the next day, we have a lot more workup to do. We have ways that we can stain the tissue and molecular tests to confirm our initial impression. So in addition to brain and biopsies and excisions. I also diagnose disease in nerve biopsies and in muscle biopsies. So you can see there's a lot of different facets to neuropathology, and even though it is a very specialized subspecialty, if you will, there are still many facets. So there's quite a diverse range of specimens that I see. And that's actually something I really love about neuropathology. Brain tumor pathology is so different from Alzheimer pathology, which is so different from muscle pathology. And as we learn more about each of these areas become more complex. So pathology certainly keeps you on your toes. We do most of our work behind the scenes, so many of our patients never get a chance to see or really understand what we do. So I'm really excited to be here today with you and kind of show you a little bit of what I do. Um, and I think a lot of people don't realize there's this whole fleet of doctors that care immensely for you that you don't even know. So if you'd like, or if the audience would like to learn more about what I mean and what pathologists do day to day, I would invite you to, if you are on Twitter, search the hashtag I am your pathologist on Twitter and just read through the posts. I actually think that these posts are the most accurate reflections of I have ever seen on what it is really like to be a pathologist. And I just wanted to read two of them to you today while I have you here. One is from a fellow neuropathologist, actually Dr. Maggie Flanagan, and she is a leader in dementia research. And she runs the neuropathology core for the ADRC at Northwestern in Chicago. So her hashtag I am a pathologist post reads, "Dear patient, I performed your brain autopsy and explained the etiology of your dementia to your grieving family. Your kids all decided to get tested for the genetic mutation that was found in your brain. You'll never meet me, but I care about you deeply. Hashtag I am your pathologist."
Wow.
I know the first time I read through these, and even now when I go back to them, they bring tears to my eyes because it's really, we do care immensely, and it's kind of unfortunate that we never get to actually meet our patients.
Mhm.
The second one that I wanted to read to you is from a leader in lung pathology, actually, Dr. Sanjay Mukhopadhyay. He says, "Dear patient, I spent hours using a microscope to find a super tiny bug in your biopsy." And he's referring to an infection. And this really is the case. It takes hours sometimes to find a little microorganism. So he said, "I spent hours using a microscope to find a super tiny bug in your biopsy so we could figure out what caused that lump in your lung. I can assure you it is an infection, not cancer. You will not meet me, but I care for you deeply. Hashtag I am your pathologist." So I just want to really relay to the audience that pathologists are physicians that care deeply for you, both in life and in death.
Absolutely. That's a very important message that definitely gets missed, I think, in a clinical practice. The patient doesn't see. So,
Yeah, it's easy. It's easy to miss.
absolutely. Okay. So, what tools does a neuropathologist typically use?
Well, you can actually see some of my tools right now are actually, if I turn my screen a little bit, my best tool here is, you can see a little bit of my microscope there, is my microscope. So between my eyes and my microscope, those are the tools that I use constantly. What you can't see in the room with me now are the handfuls of skilled technicians that actually create the slides
Mhm.
that allow me to make the diagnoses. So, speaking of people behind the scenes, there's even more people that we usually don't get to either talk about or see as patients. Um, and they deserve a substantial amount of credit. And I can't emphasize that enough. It takes a lot of skill and practice and constant troubleshooting and problem solving to be a good histotechnologist and to produce the kind of slides that I will show you shortly. And they really are visually beautiful. And may not be able to see right now, but I actually have quite a few pictures in my office of the histology of different diseases, because it really is visually very beautiful.
Mm.
It takes a lot of skill to be a good histotechnologist and produce those slides. And I always say we don't have any good histotechnologists here. They're all phenomenal histotechnologists. So before I even can begin my process of diagnosing under the microscope, they work their magic in our histology department here at the hospital. And they're processing the tissue and staining the tissue, so that by the time I receive the small little glass slides, I have all of the different stains that I need to highlight different cells and different protein aggregates. And our histology team does stellar work. And it really is an integral part of allowing us as neuropathologists to make diagnoses, and particularly important in being able to render a diagnosis of Alzheimer's disease, because there are several stains that are needed, which I will show some of to you today.
Very good. So your microscope and your team, those are your two major
Exactly.
components. Okay. Okay, so we're going to talk about postmortem now. What steps do you typically take when you receive a brain for autopsy?
Okay. So I will start my examination looking at the external surface of the brain. And the tissue has already been placed in fixative when I'm doing this, which allows the tissue to be a little more firm and retain its shape, so I can do more of a detailed examination. And so everything I'm doing in the beginning is without any sort of dissection or any cutting into the tissue. And what I'm doing is looking for signs of atrophy or tissue loss, bleeding, any signs of tissue damage, which could tell me that there was a prior vascular insult, meaning a stroke, for example. And all of those things can be seen with the naked eye if you look closely. And this is a good time for me to tell you that we are, as neuropathologists, doing research for the ADRC. We are blinded to the clinical diagnoses, which means that we don't know what the patient's neurologist has diagnosed the patient with during life. We are completely blinded to the clinical diagnosis. So this is when the detective work begins. I really have to take all the clues that I can to be able to get to an answer to the question, does this person have Alzheimer's disease and or a related dementia?
Dr. Perez Rosendahl, why is it important to be blinded to the clinical diagnosis?
It is really important for all research to have, in certain situations to be blinded. And I think that way you go into it without having any preconceived notions, and it allows you to really gather all the information instead of perhaps honing in on a certain finding.
Mhm.
So after I look at the outside of the brain, and then I begin to dissect the brain, and we will do slices that are about a half a centimeter to a centimeter. And so once the brain is sectioned, I have more detective work to do. And again, I'm looking for very similar findings as I described previously. So atrophy, areas of tissue damage, and we're also using our hands a lot, looking for areas of tissue softening. That would tell me that there's tissue damage. And again, usually those areas of tissue damage are from prior either small or large strokes. And I'm documenting all of this by taking photographs and in a detailed neuropathology report. So all of the neuropathology data that I collect on each research participant is going to have data on not only the microscopic findings, but also the macroscopic.
Mhm.
Everything that you can see with the naked eye.
Mhm.
And all of that data goes to the National Alzheimer's Coordinating Center, and they collect the same standardized set of data from all the ADRCs across the United States, and that is available to all researchers.
Great. Yes, thank you for reminding everyone. That's an important point.
So the last step really is for me to select the areas that are standardized, and I will dissect out those areas in a standardized fashion and turn it over to our histology department for them to then make the glass slides for us to look at under the microscope.
Very good. Okay. Now, speaking specifically about Alzheimer's disease, is it true that the only definitive diagnosis for Alzheimer's disease comes with an autopsy?
That is correct, Dr. Whitbrock. Yes, actually, it is true that the only way to definitively diagnose Alzheimer's disease is at autopsy. The pattern of the pathology becomes quite widespread. So the only way to adequately examine many of the areas would be at autopsy. It wouldn't, for example, be possible to just take a singular small biopsy of the brain. It
Mhm.
really is necessary to sample many regions and several that are quite deep. So that's correct. You really would need to do that at autopsy, and that is still the definitive way to confirm a diagnosis of Alzheimer's disease.
Very good. Okay. So, what are the pathological features that define Alzheimer's disease?
Sure. This is what I think I've been waiting to show you guys. I'm going to go ahead and set up my share screen function so I can see you what I can show you what I actually look at under the microscope. And I am ready to share when you are.
All right.
Okay, so what we're looking at here is a section of cortex. Now, cortex is the very outer surface of your brain, and it is folded in gyri. So that's why you can see there's a finger-like projection of tissue that is folded in this manner here. So this is a section of cortex, and I just realized that I had my pointer on the wrong screen. So I was referring to this here as a gyrus. And what you want to pay attention to at this power, you may be able to see, if we're just looking at color, that there are different shades of pink.
Mm-hmm.
So there is a lighter shade of pink that goes around the edge here, and then a darker band of pink along the middle. Hopefully the audience can see that.
I can see it.
Okay,
Yep.
I was just hearing some feedback. So essentially what is creating the different shades of pink is the amount of myelin that is down here in the white matter. So the very external surface that we're seeing here is what's known as gray matter. And gray matter is an area that is made up of neurons. And then deep to the gray matter is the white matter. So if we go a little bit closer, we will be able to see those neurons that I mentioned. Now, there's probably a lot of cells here that are catching your eye. Um, and I always joke with people, neuropathology is simple. You only need to know like 3 or 4 cells. And the most important one, or the biggest one that's probably catching your eye here, are the cells like this.
Okay.
Now, they're sort of triangular shaped or pyramidal. Those are the neurons. That's how you know you're looking at a neuron. They're going to be the largest cells, and generally speaking, a lot of the ones in the cortex have this pyramidal shape. You may be able to just make out another one here,
Uh-huh.
and there's quite a few in this picture. All of the other cells that you're seeing are the supportive cells, astrocytes and oligodendrocytes and microglia. There is another big structure that you could probably see. There's a few of them here, actually. These sort of round structures, these are blood vessels. So
Oh.
To orient you, I should also point out that you have large, or they're actually small, they look large here now that we're looking under the microscope, but small capillaries and arterioles in the cortex. So from here.
So I have a question. You
Sure.
mentioned myelin. What is myelin and what does it do?
Thank you for reminding me to tell you. So down here in the darker pink areas are the cells that produce myelin. And myelin wraps around the axons of our cells and protects them. It forms a protective layer. And so cells which have, or areas which have more myelin will appear more pink on this, what's called an H&E stain. And let me go back up to an area up here and just point out one more thing to you. I pointed out the large neurons. Here we have another one here, and there's another one here. But actually, what I think is really fascinating is all that pink in the background.
Uh-huh.
It kind of looks like a pink, like felt.
Yeah.
That is the projections from all of the cells. So all of the axons, all the dendrites, all of the cytoplasmic processes that are connecting these cells together forms this pink meshwork, which is known as neuropil. Now, in order to see the hallmarks of Alzheimer's disease, we have to do stains. You can actually sort of see some of the amyloid plaques and tangles on H&E, but to make it easier, at least for our audience today, and because we always do these stains anyway, it makes it much easier to quantitate. We do a stain for beta amyloid. So the two hallmarks that you're looking for are amyloid plaques and then tau tangles. So amyloid is actually going to be found in two places, and on this stain, it's going to appear brown. And I know you're probably looking at this and saying, I see all kinds of brown, but let me show you which brown your eyes should be looking for. So we're looking at really dark brown areas like this. So these round aggregates are the positive areas. So all of the dark brown areas have amyloid, beta amyloid aggregates. So
Okay.
this right here is a amyloid plaque. And it's extracellular, and they're quite large. So even when we look at this section on lower power, you can see all of these dark brown sort of round splotches are amyloid plaques. Now you're also probably noticing that you have, here's your blood vessels, and they're brown. So
Yeah.
there's a lot of amyloid in the vessel walls. So that's another feature of Alzheimer's disease. You see extracellular amyloid deposits and in the vessel walls. This
Wow.
is known as cerebral amyloid angiopathy.
So you see the plaques around the neurons, but you're also seeing it line the blood vessels?
Exactly.
Okay.
Exactly. Yes. So amyloid plaques around in the neuropil of the brain, outside of the cells, and in blood vessels. And so the second thing I need to show you is what's known as tau tangles or neurofibrillary tangles. Now, I found the most perfect one to show you right before this, and I circled it here. Now, remember that our neurons have a pyramidal or triangular shape. Most of them do. So tau is actually inside the cytoplasm of the neurons, and so it takes on the shape of the neuron. So here you can see you have a neuron, and it's full of brown. Again, brown is positive, and in this stain is staining for tau. You can see that there's a lot of tau accumulation inside of the cytoplasm of this neuron, and it has actually highlighted one of the extensions or processes coming off of this neuron here. So this is a tau tangle, and if I back up, you can see there's a lot of tau tangles here. There's another one here, and they also form these round structures similar to the amyloid plaques in the same location. Amyloid plaques also will have a component of tau. So you can see here as well, there is, and these are referred to as neuritic plaques when you're looking at the tau stain, and there's another one here. So we have tangles and neuritic plaques.
Are you showing us the same brain? So you're showing us the amyloid plaques and then the the tangles on the same brain. Is that
Exactly.
okay?
Yes, yes. It's actually the same brain and it's the same area.
The cortex.
Um, yeah, same section, same area. If you look at the way these blood vessels are arranged here, you'll see that same arrangement up here. So I did try to show you the same brain, same area. Here's those blood vessels again. And we were looking down in the cortex, the same
Uh-huh.
area.
Is the slide that you're showing us, or the slides, showing a lot of Alzheimer's disease pathology?
Ooh, good question. They are. They are. This is quite significant. In some instances, you really have to search for the neurofibrillary tangles.
Mhm.
But in this case, we see quite a few, and they're in every field. When I move the slide, you can continue to see multiple neurofibrillary tangles and the neuritic plaques. And here you're seeing more neurofibrillary tangles. So this is quite severe. Now we would actually need to look at several areas and score several areas in order to give a complete full scoring of the Alzheimer's disease pathology. And then that gets rendered as a diagnosis of either, depending how severe, low, medium, or high Alzheimer's disease neuropathologic change.
Mhm. So you mentioned the cortex. Where are some other areas of the brain where you would see Alzheimer's disease pathology?
So the first place that you'll start to see these neuritic plaques and neurofibrillary tangles is the hippocampus. So the hippocampus is in the temporal lobe, and our temporal lobe, if my skull was see-through, would be right about here, right by your earlobe. So in the temporal lobe is what houses, or where your hippocampus is housed, and that's an area that's very, very important in memory function. And so that is the first place that we will start to see neurofibrillary tangles.
Okay. But just seeing it in the hippocampus doesn't necessarily indicate Alzheimer's disease. Is that
Correct. That
okay?
is the first place that it starts, the neurofibrillary tangles at least. But then it will spread through into the cortex in many areas. And amyloid plaques will start in the cortex and then spread to other areas.
Oh, okay. Very good. I think that I could have you on this program 10 more times and we still wouldn't get all of the questions I have
That's
for
true. That's true.
you.
Yes, there's so much to look at under the microscope. And we've talked about Alzheimer pathology, but we also mentioned related dementias. So there's other protein aggregates and structures that we're looking for, and other stains that we do to look for those. So yes, as you said, there's definitely a lot to look at.
Absolutely. Okay, maybe we have time for one more question.
Okay.
So actually you mentioned that there are other stains, other features that you look for. What are some of those other things that you might look for?
Oh, yes. Actually, I probably should not have stopped sharing. Let me, if I
Sure.
could, share my screen one more time here. I'm ready when you are.
We have probably about 30 seconds.
Okay. This is real quick. I'm going to show
Okay.
you. If you remember, I was showing you the normal appearance of the background tissue. Usually it's just that homogeneous pink.
Mhm.
When you have tissue loss, say, for example, an infarct or a microinfarct, this is what it looks like. This is a microinfarct. So you're seeing all of these spaces, and you can actually start to make out individual cell processes
Mhm.
and axons. And so this is something that we see quite a bit from vascular disease, which is a microinfarct.
Is that a stroke?
It's a small stroke.
Okay.
Exactly. Yes, yes.
Very
Yes, so
cool.
you've had tissue loss here, and you can actually start to make out an axon here. You should never be able to see individual axons. Usually your
Mhm.
neuropil is so packed that it just looks like that homogeneous pink.
Mhm.
And so that's how we know, even when we look at low power, you'll see, oh, there's a really pale area here. And then there's another really pale area here. So these are microinfarcts.
Wow. Well, thank you. Thank you so much for sharing.
Sure. Thank you so much for having me on.
Yeah. Okay, and thank you for those of you who attended today live. You can access this and past Ask the Doc episodes, podcasts, and more on our YouTube channel and on our website at mind.uci.edu/mindcast. Next month, I will be joined by UCI Mind neuropsychologist, Dr. Michelle McDonald, who is going to discuss diagnosing memory problems in the clinic. To learn more about research at UCI Mind, you can visit our website or consider signing up for the UCI Consent to Contact Registry, or C2C. To learn more about research studies like the one we talked about, the ADRC study, that might be right for you. Take care, and we'll see you next month for Ask the Doc on UCI Mindcast.